Welcome everyone to a deep dive into the world of veterinary medicine. Today, we're exploring a fascinating case study published in BMC Veterinary Research, which sheds light on the diagnosis and management of a rare condition in dogs called polymyositis. The article, titled Successful Diagnosis and Treatment of Canine Polymyositis, Utilizing MRI and Immunohistochemistry for Accurate Detection, details the journey of a 5-year-old poodle whose symptoms presented a diagnostic challenge, ultimately overcome through the innovative use of magnetic resonance imaging, or MRI, and immunohistochemistry, or IHC. This study provides valuable insights into how we can better understand and treat inflammatory myopathies in our canine companions. The authors, including Yungwoo Han, Kunhwan Zhang, Sungbum Cho, Suyun Kim, Songju Oh, and Hyung Kim, from the College of Veterinary Medicine at Cheonam National University in Korea, have shared their detailed findings in this open-access article. It's licensed under a Creative Commons Attribution Non-Commercial No Derivatives 4.0 International License, which allows for the sharing and distribution of this research, provided it's not used for commercial purposes, and the original authors are properly credited. The corresponding author of the article is Hyung Kim. Inflammatory myopathy, in general, is classified into two main categories: generalized inflammatory myopathies, or GIM, which affect muscles all over the body, and focal inflammatory myopathies, or FIM, which are limited to certain muscles or muscle groups. This case focuses on a specific type of GIM called polymyositis. The study begins with the case presentation. A 5-year-old male poodle, already castrated, was brought to the veterinary hospital showing signs of lethargy and an inability to exercise. A physical examination revealed muscle atrophy in the hind legs. In fact, the circumference of the left hind leg was only 11.7 centimeters, and the right was 12.1 centimeters, and swelling in the left popliteal lymph node measuring 10.6 by 5.2 millimeters was noted. Although initial orthopedic and neurological evaluations didn't point to any specific abnormalities, the dog showed a pain response at the spinal T12L1 level, and spinal X-rays indicated slight narrowing in that region. Biochemical analysis was also critical in this early assessment. Significantly elevated serum levels of aspartate aminotransferase, or AST, at 509 units per liter, which was well above the reference range of 0 to 50 units per liter, and creatine kinase, or CK, levels that exceeded the measurable limit, which is above the reference range of 10 to 200 units per liter, were detected. These abnormal biochemical markers strongly suggested muscle damage. The patient's complete blood count was normal. Initially, intervertebral disc disease, or IVDD, was suspected based on these findings. To further examine the dog's condition, the veterinary team conducted magnetic resonance imaging, or MRI. The MRI results, however, did not support the initial suspicion of IVDD, but instead showed significant changes in the muscles. The images revealed hyperintensity, which indicates inflammation, on T2 weighted and T2 stir images, along with ISO to hyperintensity on T1 weighted images across many muscle areas. To confirm this diagnosis, a muscle biopsy was taken from the most affected areas, which were the bilateral biceps femoris muscles of the hind legs. Histopathological analysis revealed moderate infiltration by inflammatory cells, such as lymphocytes, plasma cells, and macrophages, and degeneration of the muscle tissue, along with some mild necrosis. Another test was conducted to rule out myasthenia gravis, which measured the acetylcholine receptor antibody and was also below the detection threshold. Figure 3 in the article provides a detailed view of the IHC results. Image A is an H and E stain image of a tissue section near the one used for IHC, showing the infiltration of inflammatory cells to assist with the interpretation of the IHC findings. Image B shows the CD8 positive staining for cytotoxic T cells, with red arrows indicating positive areas. Image C shows the CD4 positive staining for helper T cells, also with red arrows highlighting the positive areas. Finally, image D shows VEG-positive staining, which is suggestive of an angiogenic reaction in the muscle tissue and includes the capillary, which is indicated by an arrowhead. Based on these findings, the dog was diagnosed with immune-mediated polymyositis. With the diagnosis established, treatment was initiated using immunosuppressive medications. The dog was given prednisolone, at 1 mg per kilogram twice daily, and azathioprine at 2 mg per kilogram once daily. Within 1 week, the patient's serum CK levels had reduced dramatically from 2,815 to 108, which falls within the normal range of 10 to 200. The dog's tolerance for exercise, measured by the length of time he could walk during strolls, increased from about 5 to 20 minutes. Also, the circumference of the atrophied hind legs also increased significantly, from 11.7 centimeters to 17.1 centimeters in the left leg and from 12.1 centimeters to 19.2 centimeters in the right. The previously enlarged left popliteal lymph node also decreased to normal size. However, a decrease in platelet count was detected, which was likely due to azathioprine-induced myelosuppression. The platelet count had gone from 358 K per microliter to 168 K per microliter, which is at the lower limit of the normal range of 148 K per microliter to 484 K per microliter. As a result, azathioprine was switched to cyclosporin at 5 mg per kilogram twice daily. The platelet count subsequently normalized, rising to 454 K per microliter. After about 13 months of management, the patient showed a significant improvement in exercise tolerance, and the serum CK levels remained within the normal range. The circumference of the hind legs continued to increase and remain normal. No abnormalities were observed in the dog's gait. This successful treatment is a testament to the effectiveness of immunosuppressive therapy when used properly. Figure 4 in the article shows how serum creatine kinase or CK levels decrease over time following the administration of immunosuppressive drugs, and the increase in hind leg circumference. The discussion and conclusion section of the article underscores the significance of MRI and IHC in diagnosing canine polymyositis. While the expression of MHC1 is highly sensitive, it may also show positive results in other muscle disorders. Thus, MHC2 expression is considered more specific for immune-mediated myositis. Other markers such as B-cell markers like CD20 or CD21, and macrophage markers like IBA1, CD11, or CD68, are also used in the diagnosis of canine myositis. However, in this study, IHC was performed only for T-cell lineages due to the lack of staining reagents for dogs. According to the authors, inflammatory cells infiltrating the muscles in immune-mediated polymyositis are mainly T lymphocytes, specifically CD8+ and to a lesser extent, CD4+. Although the IHC results indicated that CD8+ T cells did not exhibit a significantly larger proportion of positive reactions compared to CD4+ T cells due to overstaining extending to the cytoplasm and CD4 staining, the authors determined that CD8 and CD4 showed similar levels of expression when assessed only in areas of inflammatory cell infiltration. CD8+ T cells target and attack muscle fibers expressing MHC1 antigens by releasing perforin granules which cause muscle fiber necrosis. CD4+ T cells are also involved in autoimmune reactions and are capable of cytotoxic effects. The predominance of CD4+ T cells in this case may indicate that the polymyositis is in an early stage, where CD4+ cells help initiate and coordinate the immune response by recruiting other immune cells like CD8+ T cells, and their cytotoxic response becomes more pronounced as the disease progresses. VEGF also plays a vital role in angiogenesis and tissue regeneration. In humans, increased VEGF expression is observed in the early stages of polymyositis. This is thought to be a response to repair damaged muscle fibers and capillaries. The expression of VEGF may be useful for differentiating between the acute and chronic stages of polymyositis. The authors also mention that the analysis of myositis-specific antibodies, or MSA, and myositis-associated antibodies, or MAA, is important in the diagnosis of polymyositis in humans. But currently, studies on these antibodies in dogs are limited. The only blood test available to detect antibodies in canine inflammatory myopathy is the measurement of type 2M antibody, which is not found in other muscle diseases except in MMM. In this case, while the MRI suggested the possibility of MMM, the negative type 2M antibody titer and the lack of clinical symptoms ruled out the diagnosis of MMM. The treatment regimen in this case, which included a combination of immunosuppressants, is preferred to minimize side effects from corticosteroids. Prednisolone and azathioprine are the most frequently used combination. Cyclosporin has also proven to be effective in treating polymyositis in humans, and in some cases in dogs. In conclusion, this case study underscores the importance of MRI and IHC in the accurate and timely diagnosis of immune-mediated polymyositis in dogs, particularly when traditional methods like EMG are not feasible. The successful management of this case further emphasizes the effectiveness of immunosuppressive therapy. That brings us to the end of our exploration of this fascinating case study. We hope you've gained valuable insights into the diagnosis and treatment of canine polymyositis. From Vet NeuroJar, keep those minds inspired, hearts light, and tails wagging.